And I'm also going to describe in a very short nutshell the delivery of SBIRT. So as for the definition of screening and brief intervention and referral for treatment, there are different definitions, but they all agree that it's a comprehensive approach because it brings different or all elements of care to the patient. It's integrated because it combines services, and it's public health approach because it recommends global screening. Therefore, as such, it has the potential to increase access to care for persons with substance abuse, potential to foster a continuum of care for this type of patients, and also improve their linkage between the healthcare services and substance abuse treatment services. The components, as you can see, are screening, brief intervention, and referral for treatment, which I will talk to you about a little bit in a little short time. So, as for why SBIRT is important, it is important because I'm just going to give you the emergency medicine, emergency department example. It is important because at-risk drinking and problem drinking and hazardous drinking is quite prevalent in emergency department setting where these patients receive care. So what does that mean? That means that this population can benefit from screening and brief intervention, and of course, the groups who are dependent drinkers, in addition to screening and brief intervention, can benefit from referral to treatment. So it's also an issue for the nation in general, where a high prevalence of adults report having alcohol use disorder, and alcohol use disorder being the third leading preventable cause of death in the United States. Thousands of people dying from its related causes. It has huge economic burden in the nation, much of it related to binge drinking, and also has burden of care where alcohol use disorder patients account for high percentages of patients who receive care from inpatient and outpatient clinics. And of course, in the ED, still there is a high percentages of patients who screen positive or they have a detectable amount of alcohol in their breath or in their blood. So data also shows that patients have favorable attitude toward discussing alcohol use disorder with their patients, with their providers. Overwhelming majority of patients have said that they will give providers an honest answer if the question is asked, and that they expect their providers to ask them about their drinking behavior if it has anything to do with their health condition. And also, a large percentage have said that they strongly disagree if we think that asking them about their alcohol behavior will annoy or embarrass them. Screening and brief intervention is an effective tool. This chart shows you that its component, including screening, brief intervention, treatment, referral, all its components has been effective in reducing alcohol misuse as well as tobacco use. So, and then if you look at the screening, and I'm afraid to move this. If you look at the screening and the referral for treatment component, you can see that it also has shown evidence of effectiveness across different health conditions. And as for the other elements, there are suggesting there are promising evidence, and also there are areas that still need more research. Now, earlier ED studies across the nation have shown that SBIRT is feasible and it can and it's effective. What do I mean by that? ED providers who receive training on SBIRT across these studies showed that after 3 months they favored implementation of SBIRT with their patients. And also patients who did receive SBIRT via these providers did report lower level of alcohol use 3 months after the intervention, and also 12 months after the intervention, although the 12 months report or result was not as significant, suggesting that some booster intervention might be ideal. So eventually, as an effective and feasible tool, it was promoted by different entities and organizations in the United States. In 2006, ACS mandated that all ED setting used SBIRT. In 2007, CMS allowed hospital EDs to be reimbursed for alcohol and drug SBIRT, alcohol drug-related SBIRT, and also eventually it was endorsed by U.S. Preventive Health Services Task Force as one of the top cost-effective prevention activities. In fact, in a sense, they say that economically it makes sense, and that they also added that it's as effective as flu shots for elderly. This chart shows you that as a tool, it's highly flexible intervention that can be used across different settings. It has been used, there are tons of evidence showing that it's effective and it's feasible in primary care settings. It's been used in more challenging settings such as homeless facilities and also veteran hospitals and all the others that you can see. It also is specialty friendly. It has been used across different specialties. Most commonly has been used in primary care settings such as family medicine practice and internal medicine, and has been, as you can see, across United States by other specialties. Now let's talk about components of SBIRT. I hope that by now I have sell the product, and now let me tell you that what are the components. As again, it's screening, brief intervention, and referral for treatment. So as for screening, this chart shows you different types of screenings that have been mostly used in alcohol and drug research. The table shows assist. At the top of the table is assist, which is more general. Screener includes alcohol, tobacco, and other drugs, and down to tweak, where it has been developed mostly to assess risky drinking for pregnant women. However, SBIRT researchers mostly use audit, which is alcohol use disorder identification test, which has 10 items, and the range of the score runs from 0 to 4. And just like any other tools, different scores correlate with different levels of risk, and for different levels of risk, there are some actions suggested or recommended in terms or some intervention. So brief intervention. What is brief intervention? It's really a short 5 to 10 minutes, sometimes 15 minutes counseling, and the goal of brief intervention is to change behavior. And we hope to do that by raising patients, and I keep saying patients and client, the person, all interchangeably, since there are different people. People are coming from different settings. So basically, raising patients' awareness about their substance abuse or alcohol abuse, and hoping that by showing a relationship between their substance abuse and we can motivate them to make some changes. And we often use presenting a problem as one of the as an element to increase their awareness. This sometimes, I don't know whether you have heard about window of opportunity or teachable moments, where if indeed as a provider we can see that there is a relationship between the reason the patient is in the office or having a session with you and their drinking behavior. So that's one way, one good way to raise their awareness. And also when you talk to them about the results of their screening. So that's the screening and brief intervention. Now, to utilize brief interventions, it is necessary that you do it with motivational interviewing, or you do it within the motivational interviewing style. And so in order to be able to follow motivational interviewing style, you have to know the definition. I'm going to talk to you about the theory behind it, some of the core concepts, some of the skills that you have to master, and also MI processes. This is a very simple definition. It's an effective way to talk with people about change. And you may say that, why do we need to talk to people about change? Isn't that something that we do when we think that is necessary? In fact, the fact is that think about the last one that you wanted to change. It's a hard decision to make. It's not because we are being resistance or we oppose change, only because change is hard and we have motivationals, and sometimes we see ourselves in an ambivalent position, which means that we want to change and we don't want to change. So and that creates anxiety. To alleviate anxiety, we procrastinate and we keep staying in the being in that ambivalent position. No, so ambivalence is actually normal. It's just that when you're stuck with it, then that becomes an issue. And motivational interviewing helps to resolve it so that the person can move toward change by eliciting person's own reasons for change, because we know that when the reason comes from the person, it is more effective than when people tell you what to do. So as a theory behind motivational interviewing is stages of change, and basically it's going to help the provider or the counselor to find out where the patient or the person or the client is in terms of their changing their risky behavior. Are they not still thinking about change? Are they contemplating but they are ambivalent situation? Are they determined to make change but still considering strategies? Are they taking a step toward change but haven't stabilized, or whether they have reached their goal and they are trying to work to maintain it, or are they in the relapse stage, which actually is very normal part of the stage of change. So we often use readiness to change tool to figure out is a tool that helps physicians or clinicians or counselors to assess where their person is in terms of the readiness to change. So we basically ask how ready are you to change your drinking, and you can also ask how important it is to make the change, or how confident you are. And then based on the answer, the score that they give, you can always follow up by saying why 5 and not 4, or why 5 and not 6, and then elicit some talk change from the person. So these are the core concepts that build the spirit of MI. The first one is autonomy, which means that as a provider, you have to accept and respect patients' autonomy. It is their decision whether they want to make any changes, and you always ask for permission. It's a collaborative style of interviewing. That means that you're partnering with your patients or with clients, and their information is as important as yours. And it's evocation is the next concept, which means that you have to be able to elicit change talk from your patient or your client, and that the persuasion doesn't work. And it's also empathy that shows that you have to show understanding. It's different than, empathy is different than sympathy. Empathy means that you understand where you understand where your client or patient is coming from. Are you seeing what I'm saying? Okay, no, I'm sorry, because this is screen showing something else. Okay, so as for the core skills, these are the skills that as a provider or clinicians or counselor you have to master. And these are all skills that is those of you who are counselor already or have taken counseling lessons, you're no stranger to these skills that in MI we recommend that you ask more open-ended questions instead of saying yes and no. And the reason is because you're going to get stuck if the patient says, no, I don't want to talk about it. And when you ask open-ended questions, it helps you to learn what's in the patient's or the person's mind. Affirmations, it means that you're pointing out positive things you notice about patients. Good things that they have done, their achievement, their accomplishment, their success, and that we use that to enhance the patient's self-confidence and self-efficacy. Reflection is the most important skill in MI. You listen and understand what they tell you, what they feel, what they think, and then you either repeat it or rephrase it or paraphrase it back to them. And then summaries, and then, doing that helps you to think that, am I out of time? No. Okay. Okay, so you need 2 minutes. One. 2 minutes. So MI process is going to go 2 minutes. So then you also have to know MI processes. This is really actually very important, and it's engaging, focusing, evoking, and planning, which is, these processes are sequential in nature. You have to engage your patients before focusing on the topic. You have to motivate your patients before you're planning. And once you plan a smart plan, specific smart plan, then you're done with the brief intervention. And of course, with the referral, there are always going to be a set percentage of your population who are going to need referral, and it's suggested that use the warm hands-off and hands-off approach to referral. And this is what I actually laminated and gave it to the providers to use it in CD setting by a nutshell of whatever I said, that you first engage with your patients, you screen them, you give them feedback, you listen to what their reaction, you get their reaction, then you listen and reflect on what they are saying, evoke change talk, and summarize it, assess their readiness. If they're not ready, give them more information and develop a smart plan. If they're unsure, resolve their ambivalence, give them a smart plan. And if they are ready, just work on a plan. And these are the people who I owe everything I know about SBIRT, and of course, Sanan, who's sitting here, helped me with my injured hand with the presentation. Thank you so much.
Great job. We do have questions from UTEP. Go ahead, Utah. I'm sorry, UTEP.
Can you hear us?
Yes, we can.
Okay. A quick question first. Thank you very much for your talk. It was very, very interesting. Could you talk briefly about the potential effect size of SBIRT? How big of an effect do we expect to see? How many people would we need to treat before we would see a certain number of people benefit?
How many people you need to treat before you see a benefit? Was that your question?
Yeah, or more generally, what's the effect size for this type of intervention?
Well, Well, I think the answer to your question has to do with your methodology, the methodology that you select. It's very difficult to say. It has to do with your sample size and looking at. I mean, the effect size at this point. I think with our study, we had a sample of over 400 who showed effectiveness, and I don't have the exact number, but I am thinking that it really has to do with your methodology.
Okay.
Thank you, Dr.
Thank you very much.